Hey everybody, this is Rajam Reese. I'm here with Cory Blickenstaff. I'm the CEO and founder of the San Diego Pain Summit. And Cory Blickenstaff is a physical therapist who works with individuals who are dealing with movement-related problems such as pain or orthopedic injury, as well as employers who are struggling with the consequences of pain or injury in their workforce. He presents courses nationally on topics including application of graded exposure, graded activity, edge work, novel movements, movement variability, as well as application of care to the workplace. He's authored a monograph on prevention strategies in the workplace through the American Physical Therapy Association, and he co-hosts along with Dr. Sandy Hilton the very popular Pain, Science, and Sensibility podcast on the PT Podcast Network. And he's also going to be a presenter at the upcoming 2020 Summit, and he's been a presenter on the premier 2015 summit as well. So welcome, Cory, and thank you so much for doing this.
Yeah, thank you for having me. Of course, it's my pleasure.
So I was really interested, I found your recent blog post really interesting that you wrote for, it was titled Bring Focus to the Interaction, and it was published on Physio Network. And in it, you talk about how you mentioned a paper from Cohen et al. Suggesting a change to the International Association for the Study of Pain's definition of pain. And so their definition that they proposed was pain is a mutually recognizable somatic experience that reflects a person's apprehension of threat to their bodily or existential integrity. And just for those of you listening who don't remember what the IASP definition of pain is, that one is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Yeah. And I was curious, what made you bring that up, and what is your opinion about why the IASP definition maybe needs to be updated?
Yeah, well, for one, I think that in their paper, in Cohen et al.'s paper, they bring up several possible criticisms of that original definition. And, really, I hadn't thought of it that way until they presented it that way, really. But, some of the issues that they brought up were that some of the ways it's described, that pain is something that is based on real or potential tissue damage or described in terms of such damage. Their thoughts, I believe, if I articulate them correctly, is that way of looking at it, where you have to be able to describe it in those terms, gives a bit of an advantage or a bit of a hierarchical role to the observer, right? So, like, in order for me to be feeling pain, I have to describe it in a way that you understand it. Mm-hmm. Right? Or in terms that are consistent with what you would consider to be pain. So now there's been some back and forth about whether or not that's really a sound criticism, but I kind of like the direction that it's going. Even if you don't feel like that the original IASP definition makes that mistake, regardless, I like the direction of really making sure that the focus is on keeping the primary role as the person who has pain. So they're changed what they've tried to do to alter or fix that problem is they've called it a mutually recognizable experience. Now, when I first read that, I was like, well, wait a minute now, that makes it sound like I'm not having pain unless you recognize it as being pain. Mm-hmm. But that was not what they were trying to say. They clarified in that paper. And basically what they're saying is that an outside observer is able to observe a person in pain to the degree that they can recognize pain because they're somebody who's experienced it themselves. Culturally, there are things that we, that are consistent with, we consider people having pain. So it's not saying that the observer has to recognize a person is in pain before that person has the pain. It's just saying that there are ways that we as an observer can recognize somebody having pain, which totally makes sense, right?
Yeah, and isn't that also a problem in healthcare, is that so many patients don't feel like they're being listened to in the first place?
Exactly. Yeah. And it's, uh, they make an argument that pain is very stigmatizing in nature because it's something that we can't share. And this is the same group that kind of highlighted that term, the aporia of pain, which is something that it's a private experience that can't be shared. That part of it is very stigmatizing because if I can't see or feel or sense your pain, um, one real common observation of people who have chronic pain is that they all say at some point that they feel like somebody didn't believe them, or somebody doesn't trust them, or somebody thinks that they're after something, something extra. There's that kind of malingering type of potential that people think they might be doing. So yeah, I think that's exactly the direction that they're trying to go with it, and the reason why I really like it a lot. There are some other issues that they brought up too. So, I mean, for one, they say that, a sensory or emotional experience, like what about the cognitive or affective realms? They say that, unpleasant might not be a complete enough description of all the different ways a person might describe pain. I mean, if you look at the Melzack questionnaire, I mean, there's hundreds of ways a person might describe their pain beyond just being unpleasant.
Yeah, and this
Right.
definition is from what, 1974?
Yeah, I think 79, something like that. Yep. So it's a ways out there. So yeah, maybe due for some updating. And the other thing too about this is probably their biggest criticism of the definition, is that it says that it is real or potential tissue damage, but then this isn't in the definition. There's a rider that they attached to that definition that said when it's not associated with real tissue damage, that it is likely psychological in origin. And so they took this whole, it was an attempt to define it in terms of the biopsychosocial model and try to kind of remove some of the mind-body split stuff going on, but then they just placed it right back in these terms of it's either mind or body.
And especially now with, it's becoming more, I guess popular is the term, but now more, clinical events and conferences are starting to include the patient experience as a way of us learning, helping people who are in pain and understanding it, a little bit better.
Yeah, you were kind of a trendsetter in that regard, huh? Yeah,
I
San Diego
don't
Pain
really
Summit.
know, because I think I had planned it, but I think somebody actually did it before I did.
Yeah.
So I don't.
Yeah. Regardless, I think it's a great direction. I think those add a lot to those conferences. Sometimes we as clinicians, we sit in a big room and we listen to each other about what should or shouldn't be done. But then, it doesn't take much from a patient to say, when you say this is how it sounds to us, for us all to go, oh yeah, I never really thought of that. So,
and I was curious, something I really found interesting was towards the end of your blog post, you talk about the weaknesses in the biopsychosocial model, which of course there are weaknesses with any model. We kind of work with what seems to be the best at that time until more research comes out, or however. And you were writing about the intersubjective space. Can you talk a little bit about that?
Yeah. So, this is more stuff from Cohen and Quintner and that group. So the intersubjective space, the idea behind this is that, again, pain is a private experience, something that we can't share. So I can't experience somebody else's pain, right? And they can't share it with me, even if they wanted to or tried. So the places where we have to work on this is not directly at the personal level. Instead, it's in this place of interaction, right? So that where the space where we share, like physically as well as narratively and in other ways, that is something that each of us can add to and then take away from, right? So you and I are having this conversation right now. We're both contributing to it. And the things that we say and bring together, we each are taking back into our own personal narrative. So that space, that shared space, is kind of the workplace of the therapeutic interaction.
But you
Uh,
also, just to interject real quick, but
yeah,
you also talked about this in your presentation at the 2015 summit.
yeah, yeah,
Hmm.
yeah. They had talked about this a while back.
Okay.
Yeah, yeah. That's definitely where I got it from. And
Okay.
yeah, and so, but they've built on it over time, and this new definition is meant to kind of encompass that as well. Um, and then as far as so before I jump ahead, so that uh, it gives us kind of some direction to our treatments. All right, so like when we're speaking with our patients, we can be listening for specific things about their narrative and the way that they're speaking about the things that they have, and because that shared space is where we can work, our ability to kind of take that in and make sense of it in terms of what that patient is experiencing helps us to help them. So that the situation requires a bit of empathy, right?
Mhm.
There's some questions about whether or not empathy is an important role in therapy, and I would argue that it is very important, right? I mean, and I think that some of the arguments are that you should be objective and it shouldn't really matter. Um, I think the term is maybe misused, and like we don't necessarily have to be, uh, you know, warm and fuzzy and that side of it to be successful. But if you don't have any idea of what your person's going through, and you can't kind of process that in terms of what it's like to be a person and the human experience, well, then that's going to be tough to deal with, right?
Yeah,
So
at least get a feeling for what, if someone comes with a trauma or something happening, at least a feeling that this happened to another human being, that's awful. And, you know.
mhm. Yeah, another guy that I like to quote a lot is Norton Hadler, and he has this saying where, when a person comes to us and says, provider, what would you do? And he says that when you hear that, you should basically translate that into what would you do if you were me, right?
Mm.
Because the situation, what I would do if I was in your situation might be totally different, right? So that again implies a real important role for empathy. We have to be able to kind of look at things um, through their situation, through their eyes. If we were to walk a mile in their shoes, and whatever missive you want to use, but we have to be able to turn it around and see, given what they're dealing with and the resources they have to deal with them, what is probably the right move for them, right? So, yeah, I think empathy is really important. Yeah. And then let's see, on the biopsychosocial model side of things. So, I go through this whole thing in my class about this in terms of, the it's often mistakenly, I think, thrown out as a theory, and it's
Mm.
not a theory. It doesn't make any specific predictions. It's based on a theory. It's based on general systems theory, which just basically says that, the whole is greater than the sum of its parts.
So a
Um,
theory is separate from a model? Is
Yeah,
that what
yeah,
you're
and
explaining?
yeah, we
Okay.
go through this a little bit too. So, a theory is something that generates predictions. A model is something that might put a theory into practice, but it doesn't necessarily have to be accurate and doesn't necessarily make any predictions. And why that might be important is that a theory, at least a scientific theory, should have the possibility of being shown that it's wrong. And if there's no way that you can ever show that a thing is wrong, then it's not a scientific theory.
Mm. And I have
So,
seen that interchange a lot in like discussions online where people will say the biopsychosocial theory.
mhm.
Um, yeah, so I think that that's a good point, that there is some confusion about that definition.
Yeah, and where that becomes important is that there's no, so if you take a sprinkle of bio, a dash of psycho, and a pinch of social, right? At what point does that recipe become pain?
Mm.
Right? There is no, you cannot make a prediction in those terms, and you can't falsify it, right? There's no way to say if a person was in pain, like, oh well, they didn't have a social component or whatever. It's
Hmm.
So for that regard, it's not a scientific theory, but it's a model to say that when a person has pain, it has dimensions. It includes all three of these dimensions, and that model has been, hugely successful in helping us be better about treating people in pain and kind of taking a more personal perspective and moving away from some of the problems that were with the biomedical approach, where it was this, thing A causes outcome B, like the germ theory,
Hmm.
right? If you've got, like the influenza virus creates the disease of the flu.
Hmm.
Um, that just doesn't necessarily play out so well in pain, especially in musculoskeletal pain. So and this is what I'm hoping to talk about in San Diego next year, is that when you look at it from that perspective, so if you take and you're looking through the biopsychosocial model at the person in pain, right? I just, think in your head, like you've had them fill out their intake form and they've said, I've got a history of depression and, I'm recently divorced and I've got osteoarthritis. And, so you're checking some of these different boxes that are on the biopsychosocial model. It gives you some risk factors that you've identified that you might try to address, but the person might not feel like that has anything to do with their problem, that they can't pick up their grandchildren and go see them play their soccer games.
Hmm. I've seen that a lot actually in my massage practice, where they'll come in and when I had a massage practice, and they'll come in and they'll say, my low back bothers me all the time, but really, I just want to be able to wash my windows and my shoulders get tired.
Mm-hmm.
So that's what I would rather. So I actually heard that a lot. It was pretty interesting, where someone would come in and there would be something that I would assume was a bigger issue. And they would say, this is actually bothers me all the time. But you know what? I'd rather have this addressed. And yeah, that's really interesting.
Yeah, so uh, there's some other movements that are out there, and one of them that I really like is the phenomenological perspective, where you're trying to describe things from what are consistent about in a certain experience. Not so it's not necessarily just a laundry list of all the ways people describe what pain is like for them. It's what seems to be consistent about the experience of pain for everybody. And so this is the the direction of this that I like, is the one by a guy's named Salius Geniusis. I'm not sure if I pronounced his name right. But he talks about it in terms of it's always depersonalizing. It always basically, the way I look at it is it kind of breaks a person's particular identity that they have, their current sense of identity or agency, and it rebuilds it in a new way.
Are you talking
And
about them describing their pain, or?
yeah, so the person who's had pain, it changes their identity. I'm no longer the type of person who does
Oh,
this.
the pain itself.
Yeah,
Hmm.
yeah. It and then it tends to rupture. Um, tends to rupture relations or interactions in different ways. You can't relate to your environment the same way. Your body is no longer the thing that is under your control. It becomes the thing that kind of controls you. Um, it's going to change your sense of relationship with yourself in terms of confidence, your ability to get out into the community and interact with others. And so those things seem to be consistent about people who have pain. And so the point I'm going to try to make in San Diego next year is that if you turn this around and you look at the way the person is having and are experiencing pain in those terms, and then look through the lens of the biopsychosocial model, then that might help give you um, some more meaningful targets of care that are going to make sense to the person, instead of this kind of real, kind of risk factor thing, like, oh, they've got depression, or oh, they've got anxiety and this and that. So, let's
Mm-hmm.
put them on an anti-anxiety medication, and let's put them on a steroid for their arthritis, and let's try to make them a friend.
And just as an aside, I think chronic pain has now been recognized as a disease. Do you think that by recognizing it as a disease, it kind of leads away from viewing it through the biopsychosocial model, and instead might make it be like, okay, well, if it's a disease, we need to throw this at it?
Yeah, I don't like that direction at all, actually. So again, Hadler's, a quote from Hadler here really kind of clarifies things for me. he says a disease is something that an organ has, and an illness is something that a person has, right? So I might have the disease of osteoarthritis in my knee, but it might not be given, I might not have any knee pain,
Mm-hmm.
right? So the knee pain is the illness. That's the thing that people come to us with. And the disease is osteoarthritis. Now, the thing is that illnesses can exist in absence of disease, and vice versa. So I kind of feel like that line of thinking, like chronic pain as a disease, is kind of that old, germ theory style of problems. Like, the influenza virus creates the flu. Like there's something about pain that brings about pain. And so it kind of keeps leading us down this road towards, there's got to be some kind of a smoking gun, something we can point to. But that's not really consistent, I don't think, with the experience. And there's lots of examples through history of attempting to medicalize illnesses and make them fit them into the box of being a disease. Some of the there's lots of pretty sad stories of homosexuals. There's even a time, I think, when orgasms were considered to be a disease. So lots of unfortunate examples through history. And I think pain, chronic pain especially, fits more in the camp of an illness. Now, that's not to say that those people don't have diseases right alongside with those things, and they might, and it's not that those aren't important, but to treat it as a disease makes it sound as if that there's some magic potion that is going to be the fix. And really I don't think it's so simple.
Yeah, because it's interesting because, just the way our minds work as humans, we want to put everything in neat little boxes and we want to organize everything. And so everything has this, cause and effect, and well, things do have a cause and effect, but we feel like we can control that if we can figure out what, will affect that. And so it seems like it's difficult to, by putting pain as a chronic disease and moving away from viewing it through that model, it seems like we're doing what our minds do, but we just can't leap outside our general thinking that we can't put it in a box. I don't know if that's ever even going to happen.
Yeah, no, I totally agree. I think you're exactly right that, this is something that we do because it's, pattern recognition is a human thing. We try to, look for thing A and B that leads to thing C. But, again, the kind of the important outcomes or the things that might be changeable, or the things that is important to a person, is that, they can't, it's changed their life in a way that they value. Right. So, I mean, how many times have we all seen people who've had their knee replaced and the disease has been removed, but that's, they are struggling with the exact same things that they were before, even after the surgery and everything associated with it has healed. So, yeah, it just doesn't fit so neatly into any boxes, unfortunately.
So what's your criticism about viewing pain through the BPS model?
Just that it kind of leads, it can lead to this this kind of a recipe approach. Like I was saying, there's, you're looking for different contributors from each of those components.
Oh, I see. So your kind of problem with that is that, so if you're trying to, work from the biopsychosocial model, you may say, okay, so there needs to be a bio, there needs to be a social, and then figuring it out, as opposed to just listening to their story and then recognizing those aspects.
Yeah, I mean, part of it is, I think you can look at it in terms of, okay, I'm dealing with things that are in the bio side of this, and in the psycho side of this, and in the social side of this, or you just end up with this giant laundry list of things that are in different areas of this. But there's some indications that just chasing risk factors, which basically that's what that is not such a successful way to handle some of these things. You know, a good example would be if you had somebody that had, you know, that said, I'm depressed, I've got clinical depression, you know, the treatment would be like, okay, well, let's give them an antidepressant medication.
Mm-hmm.
Right. And if you were to just do that in absence of all the other components, you know, that might not be so helpful. Right. But if you do that in the context of okay, now this is aimed to help you with these other aspects of the issue that you're dealing with, and those are the things that are important to get back to doing, well, then that's different. And so, you know, again, people kind of start piecing things around, like, you know, oh, I didn't forget to buy or this or that. So I think really biopsychosocial's big value is that it just makes us aware that you can't just view this from one direction, right? Things don't just have a biological component. Every biological component that you look at when it comes to pain also is going to have a social and a psychological angle to it. These things kind of come together. So I think that's just an important thing to keep in mind.
So it sounds like you're not really talking about the model itself, but the perception of the clinician of the model.
And the way that it's used. Yeah. Yeah. Yeah, exactly. It's, you know, the model is what it is. Yeah. You know, it's something that you use. So I think there are some different ways that we might use it, or different focuses that we might have when we are looking at it that might be more valuable. Might bring us more useful targets of our interventions, I guess.
Mm-hmm. So, you know, and I'll link the paper on your on this page that they'll set up from Cohen et al. But I was curious, was there anything else about that paper that really struck you?
The new pain definition paper?
Mm-hmm. Besides just the actual changing the definition itself, but was there anything else that you really felt like should also be highlighted for a discussion?
Well, let's see. So I think
You're like, I need to read it again.
yeah, well, trying to remember what all we've talked about already. So, you know, the keeping the role of the role of the patient first, I think is one of the big points that they make, and I think that that's really important. So here's something that I think at least is important in regards to this. So they talk about in the definition, it says pain is comes from a perception of threat to bodily or existential integrity.
Mm-hmm.
Now, this is
Apprehension of threat.
Apprehension of threat. So this is one thing that I think is, you know, could be more clear. And I'm sure if Dr. Cohen was here, he could straighten this right out for me. But this is the way I look at this, right? So when somebody is holding a hammer over my finger, right, that's not painful to me. The apprehension of threat, the hammer's about to fall onto my finger and could do some damage to me. Like, that's the apprehension of threat. That's the way I would look at it, to my bodily or existential integrity. If this happens, my body's going to be messed up. I could break my finger, and that might affect my ability to work. So it's threatening my existence. So to me, that's not when we have pain. When we have pain is when we perceive a loss, right? And that's where I think that phenomenology part of it really comes into play. So it doesn't have to be a true loss in the physical sense, but if I have perceived a loss that, you know, I can't, my interaction with others, my body is my vessel, you know, all those things that we talked about, if there's a loss in those terms, that is when I think you're going to experience pain. So, you know, so when I do my course, I do this thing where, you know, the way I look at this is that when a person has a perception of a threatening loss, and that threat is applied to their bodily or existential integrity, I think that, to me, that makes a little bit more sense.
Mm. And that would just be one aspect, right? Because as opposed to say you start having pain in your low back and it's your kidneys, that would not really relate to that, because your body's like, okay, there's something going on back there. It's time to go to your doctor.
Right. So, I mean, you still are experiencing pain and it's felt in the body, right? That's another important thing. It's somatic. So it's the type of pain that's a bodily pain versus like the pain of loss. Like if like if you've lost a loved one, this is meant to be talking about bodily pain. So if you are feeling, if you're feeling that kidney type pain, you're having a bodily sensation that you would describe as painful, then, to me, that means it's something that has the potential of rupturing those interactions with yourself, with others. Maybe you're not so confident that, hey, maybe I shouldn't go out and go for this run. I might have something going on with my back here that's not good. It's like you said, it gets your attention, that drives you to feel like you might need to do something about it and maybe become a patient even. So that alone signifies you're feeling it as being threatening to your body or your existence. So I don't know if that makes sense or not, but that's kind of how I look at it.
Do you, do you think that, I mean, of course, as humans, we're always trying to define things, and because that puts it seems like when we give something a definition, it makes it real and it puts it there.
Mm-hmm.
Do you think that it's valid to even try and have a definition of pain that we all go by, or what do you think about that?
Yeah, I think it's important, because, like Sandy likes to say, words mean things. Words are important. We need to be able to be talking about things from a common direction. Otherwise, we're just going to talk past each other when we try to have these conversations.
Like people saying theory instead of model.
Yeah, exactly. So I think the more clarification we have, the better. The other thing too is that, one other paper that I've really liked that came out this year was Bronnie Thompson's paper on, what people who are chronic pain experiencers, but who are coping with their chronic pain successfully. How do they describe, getting to that place in their scenario? And one of the things that they identified as common themes was that folks had identified, for lack of better terms, I forget exactly how she described it, but basically they had come up with a way to say, this is my problem. In essence, they'd been able to give it a name, right? They'd been able to come to terms with what the thing is that they have, in a way that provides some certainty about the future and how it's going to act and how it's going to respond. So, it's like you say, being able to give something a name kind of gives you power over it.
Mm-hmm.
There's lots of mythic stories and things like that are based on that premise.
In cultures, I mean, I think there's a few cultures where you had your true name that only you and really close family knew, and then you had your name that society referred to you as.
Right. Yeah. So some cultures give different meanings to it than we do, and so I think kind of similar to what we were talking about as far as how important a definition is, gives us something to work from, and something that we can try to prove wrong too. Again, I think, as far as the science part of this, as it moves forward, we need something that we can try to show that it's wrong, and having an accurate description or something that we can agree on to describe it from helps with that. So
Cool. So this is it's getting to a pretty deep conversation.
Yeah. Now let's get into the meaning of life. Yeah.
We'll have it all figured out.
That's right.
Yeah. So I know it's a little bit of a I can't think of the definition, but it's kind of far out. It's not, what we talked about, pain and the definitions of something isn't something that you can specifically use in a treatment plan necessarily. But what is something that you would, for the clinicians who are watching this, what is something that they can take with them from this conversation, besides maybe confusion or
Yeah.
whatever, but something they can take and use from it and apply it to their next patient that they have, either on Monday if this is a weekend, or the next, or tomorrow.
Yeah, I think really trying to get to those particular aspects of the patient's story, right? So, person's coming in with pain, they might just come in and say, I've got a rotator cuff tear. That's what I'm here for. That's what you're supposed to help me with. But really, that sure, you can move forward maybe with some of those things, but you're going to get much more meaningful information if you find out, you know, what does that mean to them in terms of, what they're going to be able to do in their environment, right? Maybe that's going to keep them from being able to do their job. Maybe it's going to keep them from being able to watch their kids or watch their grandkids. What are the implications of that and how they interact with others, right? So now they maybe they're in a more dependent scenario. Maybe they've got to rely on their spouse or their friends or their family to do things differently for them. Might have changed their role in the family structure and in their community. So how has it impacted that? How has it impacted their confidence, right? Like their ability to do things with their own body confidently, and just kind of what are their thoughts um, and just in terms of how they're able to do the things they want to do using their body, right? So I think that gives you a much more deep, rich amount of information that you can work on, right? Because a person is going to be much more likely to do the things that they need to do if they can see the value and how that's going to change their life in an important way in their terms,
Mm-hmm.
right? So if I got to go for a walk, on a treadmill versus I get to go back and walk with my wife again, which is something I've not been able to do for a while because my knee's been bothering me. That's, for one, way more meaningful, and for two, I'm going to be more likely to do it because it's something I want to do. It's more valuable to me. So, and that also helps give us direction to when this person's life when their identity gets reestablished, hopefully, what might be how it was before, or maybe in a new way, but feels in a way that they feel like they've got agency again. What is that going to look like? And that gives us some direction of things we can help them with.
What are some examples of some of the, it sounds like you're talking about asking open-ended questions.
Yeah.
So say you get somebody who comes in and they're like, my doctor told me I had a rotator cuff tear.
Yeah. Fix it,
And then
Cory. Yeah.
but they have that attitude like, okay, I'm here, fix it.
Yeah.
What
Yeah.
what's what are a couple ideas for questions that you might draw that information out of somebody who's just kind of like, this is just another cog in my day. I just got to get.
Yeah. Yeah. I mean, I would try to ask some questions in those ways, like, oh gosh, yeah, I see that you've had that. I've seen a lot of people that have this, and because of that, I assume this is really probably having some pretty big impact on how you can move around at home. Would you mind telling me about how that's affecting your home life, or how you're taking care
Mm-hmm.
of your family? And sometimes people are pretty stoic, and you might get an hour of information out of that question, or you might get nah, yeah, it's not affecting that. Just have a rotator cuff tear, And so, that again, kind of with that motivational interviewing approach, like you were mentioning with open-ended questions, then you might say like, oh, okay, so what you're telling me is it's really not having any impact on what you do at home. Oh no, I didn't say that. I can't fish, or
Mm-hmm.
whatever, right? So that's kind of that reflective statement part of it, where you're reflecting back to them what you thought you heard, or giving them a statement to either agree with or argue with or whatever. So,
Mm-hmm.
and you're going to have varying degrees of success with that with different people, but yeah, doing what you can do to get to those kind of nuggets of what it is they really need to be able to get back to doing.
Yeah, that's a really good suggestion, and that's a really good start of taking this to the clinic and starting to work from the BPS model. I think that's a really good suggestion.
Yeah, thanks.
Yeah, well, thank you for joining us, Cory, and I appreciate your time today. And like I said, your podcast is going to be on the page if anyone would like to check that out. And these papers that we discussed will also be on this page that people can review. And I'll also include Bronnie's paper as
Awesome.
well for people to read, because she's a really she does a lot of really interesting research. So
Mm-hmm.
I think that'll be valuable. But thanks a lot, Cory.
Yeah,
And
thanks for having me on.
I'll see you in February.
Yeah, we'll see you there.
2020, in case someone's watching this like 3 years from now.
Yeah, in the future with their flying cars.
Listening to it in their head, with the little chip in the head.
That's right.